Beta blockers work as competitive antagonists of beta-adrenergic receptors. They reduce heart rate, myocardial contractility, and cardiac output, thereby lowering blood pressure. Key examples include metoprolol tartrate, given at 50 to 100 milligrams orally twice daily for hypertension, with a maximum of 400 milligrams daily. Metoprolol succinate extended release is dosed at 25 to 100 milligrams orally once daily. Bisoprolol is given at 2.5 to 10 milligrams orally once daily, up to a maximum of 20 milligrams daily. Carvedilol is dosed at 6.25 to 25 milligrams orally twice daily. Beta blockers are preferred in patients with coexisting conditions like stable angina, post-myocardial infarction, or heart failure with reduced ejection fraction. They are not considered first line for uncomplicated hypertension unless other indications exist. Adverse effects include bradycardia, fatigue, bronchospasm, especially with non-selective agents, and masking of hypoglycemia symptoms. Contraindications include asthma, second or third degree atrioventricular block, sick sinus syndrome without a pacemaker, and severe bradycardia. ACE inhibitors work by inhibiting the conversion of angiotensin 1 to angiotensin 2, a potent vasoconstrictor. This causes vasodilation, reduces aldosterone secretion, and lowers blood pressure. Key examples include lisinopril at 10 to 40 milligrams orally once daily, starting at 10 milligrams daily. Ramipril is given at 2.5 to 20 milligrams orally once daily, starting at 2.5 milligrams. Enalapril is dosed at 5 to 40 milligrams orally once or twice daily. Perindopril is given at 4 to 8 milligrams orally once daily. ACE inhibitors are first-line therapy for hypertension, especially in patients under 55 years who are not Black. They are also indicated for heart failure, chronic kidney disease, and post-myocardial infarction. Adverse effects include a dry persistent cough due to increased bradykinin, hyperkalemia, acute kidney injury, angioedema, which is rare but serious, and hypotension. Contraindications include pregnancy, history of angioedema, bilateral renal artery stenosis, and caution with hyperkalemia. ARBs directly block the angiotensin 2 type 1 receptor, preventing vasoconstriction and aldosterone release, leading to blood pressure reduction. Key examples include losartan at 50 to 100 milligrams orally once daily, starting at 50 milligrams. Valsartan is given at 80 to 320 milligrams orally once daily. Irbesartan is dosed at 150 to 300 milligrams orally once daily. Candesartan is given at 8 to 32 milligrams orally once daily. ARBs are an excellent alternative for patients who cannot tolerate ACE inhibitors due to cough. They are also used for hypertension, heart failure, and diabetic nephropathy. Adverse effects are similar to ACE inhibitors, but with a significantly lower incidence of cough. They can still cause hyperkalemia, hypotension, and renal impairment. Contraindications include pregnancy and bilateral renal artery stenosis. For monitoring of both ACE inhibitors and ARBs, check serum creatinine and potassium at baseline, then within 1 to 2 weeks of initiation or dose increase. A modest rise in creatinine of up to 30% is acceptable and expected due to hemodynamic effects. Hyperkalemia, defined as potassium greater than 5.5 milliequivalents per liter, requires dose adjustment or discontinuation. Also monitor blood pressure for symptomatic hypotension. Thank you for watching. Don't forget to like, share, and subscribe.